I'm very pleased to share with you this presentation on one of the most important topics for diabetes patient, which is insulin use and particularly the multi-dose insulin regimen or intensive insulin dosing. So in this presentation, I will be talking a little bit about insulin and how it's a life-saving drug for diabetes patient, particularly type 1 diabetes patient, and what we should be aware of before using insulin, and what is intensive insulin dosing, what are the types of insulin that we use in the intensive insulin dosing, and how to calculate basal and meal insulin, how to do correction of hyperglycemia for the patient, and adjusting daily doses. And what if the patient chooses to diet in type 1 diabetes, and how he's going to adjust his doses. So first of all, we all know that we have two main types of diabetes. We have type 1 diabetes and we have type 2 diabetes. Type 1 diabetes is mainly the deficiency of insulin because the beta cells in the pancreas it fails to secrete insulin, and hence glucose will not be able to enter the cells and be used as for energy and for generating ATP for energy. In type 2 diabetes is different. The insulin is present, but the issue is there is an insulin resistance where the insulin does not really give the effect that we are looking for from the insulin. Today, we will focus more on the deficiency of insulin, which is mainly in type 1 diabetes, and those who are type 2 diabetes and progressed to the level that deficiency of insulin. Here in this slide, I want to show you a picture of Teddy Ryder. Teddy Ryder was one of the child that participated in the first clinical trial of insulin in 1922. On the left side, you can see Teddy Ryder on July 1922 before insulin use. This picture was taken on the day that the insulin was tried with this child. You can see how he looks on the left side, and the right side picture is for Teddy Ryder when he, in October 1922, just 3 months after the left side picture, and you can see the huge difference between the two pictures just in 3 months. On the left side, a child who's very thin, and he looks almost dying from low nutrition, very low weight. And on the right side, you can see a healthy child who looks very healthy and who looks happy also. So before the discovery of insulin, it's the only treatment for type 1 diabetes patient was a starvation diet, and which is very obvious in the picture of Teddy Ryder on the left side, and or a low calorie diet or a low calorie, very low carb diet. And low calorie diet, we mean here something like 600 calorie per day, which is very insufficient to achieve the growth of child and to achieve a healthy daily life activities. And for a very low calorie, very low carb diet, that was a very low carb diet, almost zero carbohydrates. And it was also very low in protein, which is also insufficient for the growth of a child or the growth of muscle for any patient, type 1 diabetes. And these three approaches used to help the patients to live after the diagnosis of type 1 diabetes around a few months or 1 year. And after that, they mostly get acidosis, they die. So it was expected for Teddy Ryder on the time of July 1922, if he did not use insulin at the time, that he will die within 2 or 3 months. But after using insulin, Teddy Ryder lived to the age of 77, and he was healthy person. So why this huge difference we noticed in the picture of Teddy Ryder as an example? It's mainly due to the anabolic effect of insulin, which I talked before in a previous lecture, if you remember, so quickly. So insulin is the hormone that helps glucose uptake by the cells. I mean, it helps glucose to enter the cell, and hence it's being used to generate ATP to the body. And also insulin increase the process of, or stimulate the process of glycogenesis. And glycogenesis, it means the synthesis of glycogen, which is the store of glucose in the body that can be used if the body is insufficient of food or a source of glucose. It also reduces the gluconeogenesis, which is the process of formation of glucose from other food types or from amino acids and fatty acids. It also increased the protein synthesis, and you can see this is very obvious on the two pictures of Teddy Ryder. And also it increased the DNA synthesis. You can see the graph of Teddy Ryder in the picture. And also by increasing the DNA synthesis and protein synthesis, the muscle mass of the body. It also reduces lipolysis and increased lipogenesis, which is the formation of lipid, and increased fat synthesis and storage of the body. And this is very obvious from the picture of Teddy Ryder. Now let's go for using insulin as an treatment for people who are suffering from deficiency of insulin, either due to type 1 diabetes or type 2 diabetes, which progressed to the level of insulin deficiency. So we as a pharmacist and healthcare professionals, we should make patient aware very, very well before using insulin of 4 main things. The first thing that we should teach the patient how to store insulin, that we have to teach the patient before using the first dose of insulin, because he's not going to take insulin in the hospital. I mean, always insulin will be his daily friend, and he's going to use it on daily basis at the home. So we should teach him how to store it very well in the home. We should show him when is the insulin pen can be kept on room temperature, and I mean by room temperature less than 28 degrees Celsius, or when is the pen should be kept in the fridge, and how to use how to keep and store insulin if he's traveling somewhere. The second thing, we should teach the patient how to inject himself insulin, or the parents of the client how to inject their child insulin, or where are the sites of insulin injection, and how to properly inject. Unfortunately, from my experience, I have seen patients who are not very well aware of the proper injection of insulin. The third thing, we should teach the patient the management of hypoglycemia. You know, hypoglycemia is the main side effect of insulin, and particularly in the early stage of using insulin, patient may experience hypoglycemia until they learn how to adjust the doses and on daily basis, and be able to avoid this side effect. So we should teach them the proper management of hypoglycemia, because there is an issue that the patients, when they face hypoglycemia, the only thing they know, oh, drink some juice, take some chocolates. But this is not the proper way to manage hypoglycemia, because they will take a lot of sugary things, and after 2 or 3 hours, they will get hyperglycemia, and then again, they will start to inject themselves and get another hypoglycemia. So the proper management of hypoglycemia be with glucose tablet, and in severe hypoglycemia is with glucagon injection, which can be in syringe or in a pen. Um, Also, we should teach the patient monitoring blood glucose and ketones, whether by continuous glucose monitoring or by finger prick monitoring. And we should also teach them how to monitor the ketones, because to avoid having diabetic ketoacidosis. So if they suspect there is a diabetic ketoacidosis, they should test their ketones, and if it's elevated, they have to go fast to the hospital. So let's take a quick review of the normal or physiological pattern of insulin secretion in the normal person who is not suffering from diabetes, whether type 1 or type 2. What is the normal physiological pattern? Why we need to know the normal physiological pattern? Because we need the patient who is insulin to have insulin with mimicking the physiological or normal pattern of insulin. So we have two types of insulin secreted in our body. We have fasting insulin or background insulin. And I mean by fasting insulin, what it's meant by fasting. Fasting insulin is the insulin which is secreted 24 hours in our body, and it is mainly managing the biological processes and the anabolic effect of insulin, which I have just mentioned. During our fasting time, during the time we are fasting, like today we are in Ramadan and we are fasting, alhamdulillah. So this is the time that fasting insulin is working. And also it's working while we are sleeping, while we are between meals, the time between meals. So this is the first type, and we call it fasting insulin or background insulin. We have another type of insulin, which is a mealtime insulin. This is only secreted if we take food. So if let's say like we are today in Ramadan, so we are fasting, we have the fasting insulin, and when we take the breakfast, then the mealtime insulin will be secreted. When we take the suhoor, the mealtime insulin will be secreted. Between that time, if we didn't eat any food between, for example, iftar and suhoor, then there will be the fasting insulin during the process. So in normal person, these two types of insulin maintain the blood glucose, as you see in the upper picture, the red color between the normal range throughout the day. That's in normal people. And mainly the mealtime insulin is proportion to the amount of carbohydrates or glucose absorbed from the meal that we are taking. So what is multi-dose insulin regimen or multiple dose insulin injection, or what we call it intensive insulin dosing? And in some literature, you will find it basal bolus insulin. So this regimen is actually is a regimen of insulin that attempt to mimic the body's normal pattern of insulin. I mean, as you see here, this is the normal pattern. We try by the exogenous insulin to mimic the normal pattern of insulin secretion and deliver replacement insulin using the concept of background and mealtime insulin coverage. So how is that? Let's see in this picture. Here's the normal pattern of insulin secretion, and you can see the mealtime insulin and fasting insulin. And for a patient who's deficient of insulin, and we would like to give him a replacement of insulin that might make the normal or physiological secretion of insulin. So what we give him? We give him two types of insulin. One type is the basal insulin, which is equivalent to the fasting insulin or background insulin, which is the long-acting insulin, and the bolus insulin, or what we call the mealtime insulin, which is from that short-acting and rapid-acting type of insulin. He's going to take it only if he's taking the Amin. So if the patient is fasting, like in Ramadan, for example, then he will take only the basal insulin every day, whether once or twice, the long-acting, and only before the time of iftar or at the time of iftar, he will take the bolus insulin, which is equivalent to the mealtime insulin. So that's how we might make the physiological secretion of insulin. But to do that, how we do that? So we first should know very well how to calculate the basal insulin dose of the patient, because it's different for every patient and it's not fixed, for example, for a class or group of patients. No, it's different for every patient, and we will see in the next slides how it's different. And we have to start to calculate, to know how to calculate the bolus doses of insulin. And these bolus doses of insulin, which is short-acting and rapid-acting insulin, is to calculate the doses for meal insulin, and also to calculate the doses that the patient may require if he needs a correction. What's the meaning of correction? Is to correct the hyperglycemia. After we calculate, these doses are called the initial dosing because we don't know the response of the patient. Every patient is different, and the responses to these initial dosing will be different. So after we use the initial dosing, we follow the patient, and then we do a fine tuning or adjustment of these doses to reach the actual doses of the patient. So what are the types of insulin that we use in this regimen? We have 4 main types of insulin that we use in this regimen. We have the rapid-acting insulin, and you can see here the intensity and the duration of action. You can see the duration of action is short compared to others, but it's very rapid onset, 5 to 10 minutes of onset, and then peaks within 30 to 90 minutes. And then we have the short-acting insulin, which is the short-acting insulin, which is slightly slower than slightly slower than the rapid-acting insulin. And it is start to work 30 minutes to 1 hour after injection, and it peaks 2 to 5 hours. And there's the intermediate acting insulin, and this can last longer time. And there's the long acting insulin, as you can see, which may last for 24 hours or maybe longer than 24 hours. So to apply the MDI regimen, we use the rapid acting insulin and the short acting insulin for bolus insulin or mealtime insulin, and for the correction of hyperglycemia. We also use the basal insulin. We use for the basal insulin the intermediate and long-acting insulin for the basal insulin. So some people would say, okay, we have another type of insulin injection, which is the premixed insulin, like Mixtard and Novomix, which is very commonly used, particularly in elder patient or in type 2 diabetes patient. Why we don't go for this type, and it's only, for example, 2 times dosing per day, and no need to inject the patient multiple times per day, 1 for the basal or the fasting, and 1 and 3 times, for example, if he's going to take 3 meals or more than 3 meals per day, and he's going to take like 3 or 4 or 5, maybe 5 times injecting insulin. Why don't we go for the premixed? The premixed insulin is actually a type of insulin. They have 2 types of insulin in the same injection. One is the rapid, which is in the red color, and rapid or short, and the other one is the long acting. Yes, it looks like 2 times of injection per day, and maybe in some patients who has progressing diabetes, maybe they will have 3 times per day. But this type is no longer recommended by the guidelines and the literature. And we see why it's no longer recommended, and what are the disadvantages or drawbacks of this type of insulin. So this type of insulin, the patient will inject both types of insulin at the same time, because he will inject, for each time he's going to inject, he will get some, like 30%, for example, if it's 30-70, 30% of the insulin he's going to inject is from the rapid or short acting, and the 70% is from the long acting. You will see if the patient inject himself at this in the morning, because he need to have a long acting insulin, he has to take a meal. So if he's going, for example, to fast, he will not be able to fast. If he's using premixed insulin, he's not able to fast. That's one point. And the other point What if the patient just doesn't want to eat at the time? What if the patient injected himself to achieve the presence of the long-acting, which is the black color, and he got busy, he doesn't want to eat at the moment, or the meal is not ready, or he couldn't find a store to eat or something, he will get hypoglycemia. Another point which is important, see, we have something called weak points for premixed insulin. So see these 2 points. At these 2 points, you can see the short-acting insulin is still in action. It is still in action. And in the background, the long-acting insulin is having its peak. Yes, it's a minimum peak, but it's there, the peak. I mean, peak of intensity. So at this point, the patient, if he did not take a meal, he may have hypoglycemia. So if the patient, for example, took the injection, after some time he took a snack or a meal, then he become busy or something, so, and he forgot to take a meal or something here, he may get hypoglycemia. Also, you cannot expect how is the blood glucose will be after this point, even if he took a meal, because we cannot really calculate the dose correctly according to the amount of carbohydrates in the meal, because every time he's going to inject himself, he's going to inject 2 types of insulin and not a 1 type of insulin. Another weak point we can find it with the premixed insulin is this point. See, at this point is the long-acting insulin is its own last action, and also the short-acting insulin is going to is already finished. The duration of action is already finished. So at this point, the patient may experience hyperglycemia, even if he's going to take the second dose. But before taking the second dose, they usually experience hyperglycemia. And if they want to correct this hyperglycemia with insulin and start to take this premixed insulin, it will give them more insulin from the long-acting and also insulin from the short-acting, and it will always make their blood glucose throughout the day irregular blood glucose. This irregular blood glucose, by experiencing hypoglycemia at certain time and experiencing hyperglycemia at certain time, will give the patient poor glycemic control, and it will cause a weight gain for the patient. Why weight gain? Because he will always try to treat this hypoglycemia with eating more sugary things, and weight gain. On the opposite, you will find on the right side is the normal secretion of insulin on the upper picture, and here down you will find in this picture the regimen of basal bolus, and you can find that how the MDI or basal bolus might make the so if he's, for example, wake up in the morning, take his basal insulin, and he's not very worried that he will get hypoglycemia. At the same time, he after 1 hour or 2 hours, he's going to take the inject rapid-acting insulin or short-acting insulin.
Ini hitung 20.000 ini.
So why, in brief, why MDI or multiple dose insulin injection is better than premixed insulin? MDI mimics the normal physiological pattern secretion of insulin, and based on studies, MDI has better glycemic control than premixed insulin, and that's evident by several studies, and that's why it's now the recommended regimen of insulin. It also reduces hospital complications. Premixed insulin increase weight gain, and premixed insulin increase the hypoglycemia frequency. And much more importantly, MDI has more flexibility for the patient. If they eat, they will inject bolus. If they don't eat, they will not inject the bolus, and they can inject the rapid acting just shortly 5 minutes to 10 minutes before the meal. So here comes why the MDI is better than the premixed. So let's start to know how to calculate the doses for the MDI. The first thing that we have to know how to calculate is the basal insulin, the background, and it's very important to calculate the basal, because if the basal insulin is not calculated correctly, then it is very difficult to have enough glycemic control for the patient. So it's the cornerstone of adjusting insulin dosing. And once we reach the actual basal insulin dose adjusted, it is constant from day to day, and we will not change it frequently. I mean, the patient may rarely change the basal insulin dose or require changing the basal insulin dose. He can use it for months, he can use it for weeks and months and maybe 1 year, and this dose will not change unless the patient got sick or got a disease, got infection. So that's another situation. So the role of basal insulin is to control blood glucose overnight while he's sleeping, during fasting, between meals. It's around 50% of the total daily insulin of the patient. And we will know how to calculate the total daily insulin required for the patient. The rest of the total daily insulin covers the meals, and we will see how to calculate this, inshallah. So what are the types of basal insulins that we are using to cover the basal or fasting insulin? We have two main types, which is the long-acting insulin and the intermediate-acting insulin. The long-acting insulin, we have three common types. The first and very common type is the Insulin Diglodic, and it comes in brands like Lantus, Studio, and other local brands in every country. So you may have a local brand in Indonesia. And it's usually taken once daily, and it lasts for 24 hours. So patient will take it only once a daily. And in some few cases, some patients may require to take it twice daily. So the second type is Insulin Determiner, and this comes in the brand name of Levemir or other brand names, local brand names or generic names in every country. And it's taken once or twice daily based on the response of the patient or the duration of this insulin with the patient. The third type of long-acting is the Insulin Diglodic, which comes in the brand name of Tresiba, and it lasts from 36 to 42 hours, and it takes once daily. And this type is very frequently used by type 2 diabetes who only use the basal insulin and they don't use mealtime insulin. The other class of basal insulins are the intermediate acting insulin, the MBH, and this comes in mostly in the brand names of Humulin N, Novolin N. Also, there is a generic brands in every country, and it's being used once or twice daily. Let's see how we calculate the basal insulin dose. First, we need to calculate the total daily insulin or the TDI, and then to calculate the TDI, how we calculate it. We have three options to calculate. Either the patient is coming to you, he's type 1 diabetes with non-TDI. I mean, a patient is already on insulin for some time, and his total daily dose of insulin is known for you from the patient data or the patient profile or file. And this dose means that the sum of the basal insulin and all the meal insulin that he's taking. For example, if he's taking three times bolus insulin or mealtime insulin, you sum all the three bolus insulin and plus the basal insulin, and this is the total daily dose of insulin. Another way, if this is the first time for the patient to use insulin, if he's type 1 diabetes, it's calculated from 0.1 to 0.3 unit per kg weight of the patient, and we use the actual weight, not the standard weight or the reference weight. And if the patient is the first time to use insulin, we start low because we try to avoid hypoglycemia in the early use of insulin. If the patient has type 2 diabetes, the dose is from 0.3 to 0.7 units per kg weight. And you can notice here in type 2 diabetes, the total daily dose is higher than type 1 diabetes. And the reason is because the type 2 diabetes, they suffer from insulin resistance. And so they will require more doses, higher doses of insulin. So after we have the the TDI in our hand, then we start to calculate the basal either by 50% of the TDI or 0.2 units per kg weight of the TDI, and start to monitor the fasting blood glucose and between meal glucose, and to make sure it's between 80 to 120 milligram per deciliter. Sometimes some endocrinologists recommend for the patient in the early stage slightly higher target just to avoid hypoglycemia, but this is the best range of target that we should target for monitoring. And then after monitoring, we will adjust the dose. I will show you an example how to do this fine tuning and adjustment of the dose. So let's see this patient. Here we have a Mr. MK. This patient is a type 1 diabetes patient. He's 25 years old. His weight is 70 kg and his height is 173 centimeter. So the first thing we do is to calculate Mr. MK TDI, which is the total daily insulin dose. And here the medical doctor recommended consider 0.3 units per kg. Sometimes they recommend the starting units to start, and then calculate his initial basal insulin. So the first thing, we will calculate the TDI, which will be 0.3 units times his weight, which is 70 kg. So it's the total daily dose of insulin is 21 units. So let's start to calculate the basal insulin. So method one, what we will do, the 50% or 0.5 of the TDI, 50% of the TDI, then it will be around 10.5 units, which is around 10 units, because most of insulin pen does not make half unit. So so we use I mean the full unit. We go for the lowest, I mean 10 unit and not 11 units, because this is a starting, and we try to avoid the hypoglycemia. The second method is by multiplying 0.2 in the weight of the patient, and that will give us the basal insulin dose. So 0.2 multiplied by 70, so it gives us 14 units. You can see there is a difference in units between the two methods. So if the patient is newly using insulin, what we should do, it is safer to start with the low dose. So if we calculated with the two methods, it's better to use the low dose in the starting to avoid hypoglycemia. So what we will do after that, we will set a goal for fasting blood glucose. And let's say that we set a goal, it should be below 100, and below 100 means from 80 to 100 milligram per deciliter. And then we start to monitor the fasting blood glucose for 3 days and then adjust the basal dose. Let's say the patient came after 3 days, or the patient contacted the diabetes pharmacist or diabetes educator, and then with his fasting blood glucose readings on day 1, he got his fasting blood glucose. And what I mean by fasting blood glucose, the morning fasting glucose after at least from 8 to 10 or 8 to 12 hours of fasting. So his fasting blood glucose was on day 1 199, and on day 2 is 221, on day 3 it's 215. And you can see from these readings that this is out of the target that we set for the patient. So he's suffering from hyperglycemia, and this is not the target that we were looking for. So if we want to adjust this patient basal insulin dose, we can notice from here that what we give the patient, or the dose that we give the patient, was insufficient for the patient to control his fasting blood glucose, and we need to increase the dose. How we are going to increase dose, we are going to increase the dose between 2 to 6 units. And usually it's preferred to go for the lowest increase. So we increase 2 and then monitor for 3 days, and then we increase again for another 2. So we add 2 units for his 10 units, and it's 12 units. And then what we do, we monitor the fasting blood glucose, and we ask him for 3 days to give us the reading and adjust and monitor until we reach the reading. Usually from my practice, it will take like 3 days and then another 3 days, and we will reach the actual basal dose. So let's say another situation happened after we gave him the 10 units and the patient experienced hypoglycemia instead of hyperglycemia. Let's say that you give the patient the 10 units of basal insulin and his fasting blood glucose on day 1 was 65, or day 2 66, or day 3 68. And it's very clearly that the patient experienced hypoglycemia, which is very risky, because this means probably he experienced much more hypoglycemia while he was sleeping, and this is very dangerous to the patient. So if we would like to adjust this his basal insulin dose, this means that the 10 units was much more than the requirement of the patient, and we need to reduce the dose of insulin. So we have to reduce the basal insulin. In this way, we reduce the basal insulin dose by 20%, and in some cases with children, we may reduce the dose by 30%. So let's say it's 20%. So we will reduce 10 units. We will deduct from it 0.2, which is the 20% times that 10 units. So 10 units minus 2 units, it's 8 units. Some people use to multiply the basal insulin units with 0.8, which is 80%. I mean, to take 80% of the current dose. So what we will do, again, we will do monitoring for fasting blood glucose, adjust the dose, and monitor and adjust until we reach the actual dose. It takes around 1 week to reach the proper and optimum basal insulin dose for the patient. Start to talk about the bolus or mealtime insulin. As I talked before in my previous lecture about type 2 diabetes and the nutritional therapy of type 2 diabetes, I talked about the effect of food type on insulin and blood glucose in normal person. So usually the carbohydrates will cause a great spike in insulin compared to protein and so this means that carbohydrates is the main component of the main food components that affect the insulin secretion. Why is that? Because carbohydrates will give us glucose, and glucose will spike the glucose in the blood. And so this is the main food component that will affect the blood glucose and will require an insulin to cover this this food component. So we calculate the mealtime or pre-meal insulin or bolus here in the red color on the MDI regimen using carb counting. Carb counting means we count the amount of carbohydrates in the meal and then we calculate the dose based on that. Let's see how we do. So bolus or mealtime insulin, bolus insulin dose for meal coverage is calculated based on something we call it insulin to carb ratio. What is insulin to carb ratio? Insulin to carb ratio represents how many grams of carbohydrates are covered or disposed by 1 unit of insulin. This insulin to carb ratio is not fixed ratio, and it's different from one patient to another patient. So so we should calculate the insulin to carb ratio for every patient. And this insulin to carb ratio is not like the basal insulin is fixed for a long time. It may slightly differ within the day, I mean, from the morning and the evening, and it may differ from time to time. But usually we can have it like approximately fixed for some time, for weeks, for month or something like that. But the main point, it's not equal for every patient. We have to calculate it for every patient, so it's individual. So generally, to calculate this or to make an initial insulin to carb ratio, 1 unit of insulin we consider of rapid insulin will dispose 12 to 15 grams of carbohydrates from the meal. But this is not, as I said, is not fixed for every patient. So you may find that this range can vary from 6 to 30 grams of carbohydrates, which means that some patient, 1 unit of insulin will cover only 6 grams of carbohydrates from the meal. And for another patient, 1 unit of insulin may cover only as much as 30 grams of carbohydrates in the meal, which is common in the children. I mean, the higher amount of carbohydrate. Or more, depending on patient's insulin, it's very dependent on patient insulin sensitivity. So if the patient is insulin resistant, he will have lower amount of carbohydrates covered by 1 unit of insulin. But if the patient is insulin sensitive, I mean, his insulin sensitivity is very good, he will have higher amount of carbohydrates grams covered by 1 unit of insulin. And that's why I said it's much more the higher amount of carbohydrates grams with the children, because children are very sensitive to insulin compared to adults. Sensitivity for even normal people, for physiologically normal people, differ throughout the day. It's in the morning, the insulin sensitivity is lower and it increases in the evening or night. There is individual differences between people. Also physical activity, people who are having, like for example, if the patient increased his physical activity, his insulin sensitivity will increase. If the patient is having stress in certain days, his insulin sensitivity will decrease. And all of these factors will affect his insulin to carb ratio. Like for example, today he's having an insulin to carb ratio, for example, 1 to 15, but the next day he got some stress, this insulin to carb ratio may differ, and 1 unit of insulin will not cover for him 15 grams of carbohydrates. It may cover only 6 or 10 grams of carbohydrates, this amount of carbohydrates. So what are the types of insulin that we use for meal insulin, for bolus insulin? We have these types, 3 main types. First, the rapid insulin, which is the most commonly used in the MDI, which are the insulin lispro, insulin aspart, insulin glycine, and they come in the brand names Novorapid, Ebidra, Humalog, and they also come in local brands in every country. And there is a regular or short insulin, which is like comes in the brand name of Humulin R, Novolin R, Act Rapid. And there is a new type of insulin, which is ultra rapid insulin. And this is very rapid insulin, like it comes in insulin lispro, insulin aspart, but this is very rapid insulin and can be taken after the meal. I mean, after the patient take the meal and he calculates the amount of carbohydrates he have eaten in the meal, and then he can take the insulin. This ultra rapid insulin is very useful with children, because sometimes the children, they will just go and eat chocolates or things away from their mother, and then the mother will notice that, and then she can inject them. And previously it was very difficult because they can do those things, and the mother will try to inject them rapid insulin. They get first hyperglycemia, and then the insulin cover this hyperglycemia. So we have 2 brands for the ultra rapid, the Lomjev and Fiasab. So here comes the question. Usually, sometimes some patients are prescribed on the MDI one dose of basal insulin and fixed doses for premiums. Like, for example, a patient will tell you, if you ask the patient, what are your insulin doses? He will tell you, okay, I'm taking 20 doses or 15 units of insulin for basal insulin, but I'm taking for bolus 6 units for the breakfast, and I'm taking for the lunch 6 units, but I'm taking for the dinner 4 units. So, which means that he's taking fixed doses of insulin every day. Unfortunately, this is not a proper way to glycemic control if he's taking fixed doses every day, because if I ask you, do you eat fixed meals every day, you will we don't eat fixed meals every day. Today you eat pasta, tomorrow you may eat rice. Today you eat fish, tomorrow you eat something else. So you are not, we normal people, we don't eat fixed meals every day. So if we are not eating fixed meals, we cannot ask, if the patient is not eating fixed meals, we cannot ask him to take fixed doses. So fixed doses is not the proper way to control, for glycemic control in patients who are deficient of insulin. So the better way is count the carbohydrates in every meal, and we know the insulin to carb ratio for the patient, and then we start to show him how to calculate the insulin dose for every meal. Why carb counting better than fixed bolus doses? Carb counting has more flexibility. So if they want to eat today pasta, tomorrow they are going to eat, for example, rice, or if they want to eat today low carb meal, or tomorrow the meal will be high carb. So this will help them not to have hypo and hyperglycemia. Better glycemic control than mixed and then fixed doses. So if the patient doesn't want really to learn how to change his doses, of bolus based on the meals, we should ask him to go for fixed. If he wants fixed doses, then he should go for fixed carbs pattern or fixed meal plan. Fixed meal plan that you give the patient weekly plan of meals, and you ask him, this is your meal plan for the week, and if you are going to take this meal, take this amount of units, this units, and so on. So let's see how we calculate the initial insulin to carb ratio for the patient. So to calculate the initial insulin to carb ratio for the meal insulin, we have two rules that we apply according to the type of insulin, whether it's rapid or regular or short-acting insulin. If it is rapid insulin, we use the 500 rule. The rule is called like that, 500 rule. We take 500 and divide it on the total daily insulin. And this rule is not really also fixed, because there are other rules for the rapid insulin, like, for example, 200 rule, and also we have the 300 rule. But for 200 and 300 rules, we use them with the patients if the patient, they would like to follow a low carb diet. For regular or short-acting insulin, we use the 450 rule. It's the same like the 500 rule, but we use the 450. And we use also lower rules, like the 200, 300 for low carb diet. Let's see how this is, how the insulin dose is calculated based the insulin to the carb ratio. The carbohydrate insulin dose for a meal, we take the total gram of carbohydrates in the meal and divide it on the grams of carbohydrate disposed by 1 unit of insulin. How is that? Grams of carbohydrate disposed by 1 unit of insulin is the bottom number of the denominator of, or the denominator of the insulin to carb ratio. So how is that? Take this example. If the patient, for example, insulin to carb ratio is 1 to 10. What does 1 to 10 means? That 1 unit of insulin is covering 10 grams of carbohydrate. So if he's going to eat a meal containing 50 grams of carbohydrates, this patient will require 50 divided by 10. So he will require 5 units of bolus insulin to cover the carbohydrates in this meal. Let's fix this information back in Mr. MK case. So here, Mr. MK, we calculated his basal insulin before, and let's say that this patient, by the time his total daily insulin increased up to 35 units, and his basal by the time increased up to 15 units per day. And now we want to calculate, calculate his insulin to carb ratio and calculate his meal insulin for a meal containing 30 grams of carbohydrates. Let's say that he will be using NovoRapid or insulin expert for the bolus. So we calculate first the initial insulin to carb ratio. So 500 divided on TDI, or the total daily insulin. So it's 500 over 35, and this is around 14.30, which is around 15. So what does 15 this means? 15 means that one unit of insulin covers 15 grams of carbohydrates for this patient. So initial insulin to carb ratio is 1 to 15. 1 unit of insulin disposes 15 grams of carbohydrate. So what we will do, we will use this for the patient, and we will start to monitor his brandial blood glucose and adjust and monitor, and we will see in the next slides how we will monitor and adjust this. But let's say, for example, here for this initial insulin to carb ratio 1 to 15, and if the meal is 30 grams, then means that he will require for this meal 2 units of insulin. Why 2 units of insulin? Each unit will cover 15 grams of carbohydrates in the meal. So if we ask the patient for 2 days, for example, to monitor his brandial blood glucose, means after the meal by 2 hours, and see his brandial blood glucose. On day 1, for the breakfast, he got 250 milligram per deciliter, and for after the lunch, he got 200, after the dinner, 170, on day 2, 245, and lunch 199, and for dinner 160. What you notice from that the patient is experiencing hyperglycemia after the meal. He's not experiencing within target blood glucose. But another thing that we noticed from that on dinner, it's slightly near the target that we are looking for. If let's say the target we are looking is 80 to 120 or 80 to 140, so it's close to the target on the dinner, but not close to the target for breakfast and lunch. So this means that the insulin in the insulin to carb ratio is not sufficient to cover the amount of the carbohydrates. So how do we adjust? Insulin in the insulin to carb ratio is not sufficient to dispose the carbohydrates. Like we initially said, the 1 unit of insulin covered for that patient, for example, 15 grams of carbohydrates. But this means it does not cover 15 grams of carbohydrates. It covers less than that. Less than that means the insulin to carb ratio should be changed, and it's actually, we see here, it's actually, it changes all over the day. It's not the same. We cannot use the same insulin to carb ratio here for that patient all over the day. So patient also, we can see from these readings that the patient is suffering from down effect, and down effect is the increased blood glucose in the morning. And this happens even for physiologically normal people. So what we should do, we should reduce the amount of carbohydrates in the ratio, which means that we increase the insulin to the ratio. So what we will do, we start to reduce it in a practice manner. I mean, sometimes we can ask the patient, for example, from instead of 1 to 15, make it 1 to 8, 1 to 10, 1 to 12. This means that 1 unit of insulin covering less amount of carbohydrates from the meal. So what we will do next, we will monitor the brandial blood glucose and adjust and monitor and adjust for few other days, like 1 week or something, and then we will reach the insulin to carb ratio, the accurate insulin and actual insulin to carb ratio of the patient. We will continue to monitoring also the fasting blood glucose during the same time to make sure that this elevation is not related to the basal insulin dose and not to the meal. Here, take what if the opposite happened, the hypoglycemia, for example. Here, see the patient, for example, he got after the breakfast 110, after 115, 90, 100. It looks okay with breakfast and lunch, but come to the dinner, he's experiencing evening hypoglycemia. So this patient needs a fixing for and adjustment for his insulin to carb ratio for the dinner. I mean, he's not going to to use the same insulin to carb ratio, which he used for the breakfast and lunch for the dinner. Insulin to carb ratio is suitable for morning and noon, but suggest adjusting the evening insulin to carb ratio. So how we adjust this means that the insulin was more than sufficient for the carbohydrates amount in the evening. So increase the carb in the insulin to carb ratio, meaning decrease insulin in the ratio. So suggest a new insulin to carb ratio. Make it, for example, 1 unit covers 20 instead of 1 unit covering 15. So what we will do, we will monitor brandial blood glucose and adjust, monitor and adjust. So here comes the question. The patient will ask you, if you are handling the case of the patient will ask you, how to count carbs. This is the question that usually patients will ask, how I count carbs in the meals. There are several methods to calculate carbohydrates content in the meals or certain food. The best and accurate method based on the recommendations is weighing food. I mean, to weigh food. But of course, once you will tell the patient, you will have to weight your food on a scale, then the patient will just feel hesitating to follow the MDI and hesitating to have these doses, and he'll just maybe ask you, okay, I won't fix doses when, no matter how it's give me my blood glucose, whether hypoglycemia or hypoglycemia after the meal. But we have to inform the patient they will not use the weight method for the rest of their life. No, they will use it on the first beginning time, like first week, first 2 weeks, until he knows how the weight of every type of food that he's taking in his dish. Let's say, for example, he's taking some amount of rice in his dish in daily, and then he will weight that amount, I mean, in the first week or 2 weeks, and then he will know, okay, if I take 3 spoons, 4 spoons of rice, this is the weight of these amounts. So weight food, then use carbs, percentage resources to calculate the carbs gram in the food. For example, if the carb content in certain food, how you know the carb content? You just Google it, and there is a lots of apps that helps insulin users with the carb content of the food. So let's say, for example, if the food carb content is 50%, so 100 gram of this food type contains 50 gram of carbohydrates. Patients may use apps to assist them, and now it's very easy compared to before. Another method is measuring or portion size method, and this is much more easier than the weight method. And many patients, they prefer this method instead of the weight method. This method is easier but less accurate than the scale method. And what they use, for example, measures or portions size, such as cup, glass, tablespoon, teaspoon, handful, piece. And on the apps, they just can put, for example, a cup of salad, a cup of rice, like, for example. But you can see, for example, from these 2 pictures of rice, how this method is not as accurate as the scale method, because see here, this is a cup of rice and this is a cup of rice, but they don't look the same. So applications assist patients in calculating the amount of the carbs in the meal, and there are applications for calculating insulin doses based on the amount of carbohydrates in the meal. So this is make their life easy. They just can enter what type, for example, they will enter the whole meal content, like a cup of rice, a cup of salad, for example, an apple, or half an apple. These amounts they will enter, and they will get the total amount of carbohydrates, and then they will enter their insulin to carb ratio, and then they will, the app will calculate for them the insulin dose for the meal. This method, the portion or measuring method, works very well for the low carb diet because the amount of carbohydrates is very small, so the range of error is very less. Here I would like to show you the carbs reference tables. If the patient, they wish to use, they don't wish to use the apps or something, they get these tables from the pharmacist or diabetes educator or the nutritionist or registered diabetes nurse. And they get these where it shows to them carbs per typical portion size and carbs per 100 gram. And they use this if they want to calculate manual. There is another point that we consider in carbs counting, which is fiber and sugar, alcohol in calculating both, like fibers. Fibers is part of the carbohydrate, but however, it has different calculation in calculating carbohydrates in the meal. So if fibers are more than 5 gram, we subtract half of fiber gram from the meal's carbs. So means if a meal contains 10 gram of fiber, we don't consider those 10 grams in the calculation of the carbohydrates of the meal. We just consider 5 grams of the carbohydrates. Why is that? Because actually fibers are beneficial for the patient because it reduces glucose absorption, and it actually does not spike blood glucose after the meal as other types of carbohydrates. Also for sugar, alcohol, we subtract half of gram of the meal's carbs content for the sugar alcohol. Now let's see the correction doses. Correction doses means the bolus doses that we use for the patient to correct hyperglycemia. Let's say he's suffering from hyperglycemia and we would like to correct this hyperglycemia. As you can see, when we talked about our example, during the adjustment phase, the patients experience 100 something blood glucose, and this is hyperglycemia, and we should correct this hyperglycemia. We shouldn't leave the patient in a hyperglycemic state because it's very dangerous for him, as well as the hypoglycemia. So correction doses are used to correct blood glucose when it is higher than target, or adjust before meal when blood glucose is lower than target. For example, during the fine-tuning that we were just talking about, the adjustment during stress or sick day management, during the sick day management, usually patients they get hyperglycemia. If there is a wrong calculation of the doses and the patient got postprandial after the meal hyperglycemia, we should correct it. So to calculate the correction doses, also insulin sensitivity is considered, and there is an insulin sensitivity factor or correction factor, or insulin to blood glucose ratio. This time it's not insulin to carb ratio, it's an insulin to blood glucose ratio should be calculated. Insulin to blood glucose ratio describes the amount of blood glucose lowered by 1 unit of insulin. This is not related to the food or the meal. No, this means if I inject the patient with a rapid acting insulin, how much his blood glucose is going to be lowered regardless of any meal or any other blood glucose going to be ingested. So initial calculation of insulin to blood glucose should be adjusted to actual insulin to blood glucose. So let's see how we do that. We first calculate the correction factor or correction dose. How we calculate it? By subtracting the target blood glucose from the current blood glucose and divided on blood glucose disposed by 1 unit of insulin, or insulin to blood glucose ratio. Blood glucose disposed by 1 unit of insulin is the bottom number of this ratio. Let's see this example. If a patient insulin to blood glucose ratio is 1 unit to 50, what does this mean? This means that 1 unit of insulin will lower blood glucose of the patient by 50 milligram per deciliter. Here I'm talking about regardless of the meal, regardless of the food. Like if he's just fasting and he's having hyperglycemia, and we will inject him with 1 unit of insulin, it will reduce for him 50 milligram per deciliter from his blood glucose. So if it's 250, it will become 200. This is different for every patient. They have their own insulin sensitivity. So if his current blood glucose is 170 milligram per deciliter and his target blood glucose is 120 milligram per deciliter, he requires 170 minus 120 divided by 50. So So 1 unit of bolus insulin to correct his blood glucose. Y divided by 50, this is the 50 in this ratio. So how to calculate the initial insulin to blood glucose factor? We have two rules based on the type of insulin. For rapid insulin, we use the 1,700 rule. And in this rule, we divide the 1,700 over the TDI. And there is also other rules like range from 1,700 to 2,200. I mean, you will find some literature mention 1,800 rule, 2,000 rule. For the regular and short insulin, we use the 1,500 rule, although regular and short insulin is not preferred for correction of hyperglycemia because it works short, longer than that is very fast and it will correct glycemia very fast compared to one. So let's go back to Mr. MK case and let's help him to calculate his insulin to blood glucose ratio in data of Mr. MK. Calculate his insulin to blood glucose ratio or insulin sensitivity or correction factor. So insulin to blood glucose is he's using no for rapid or insulin aspart. We use 1,700 over TDI ratio. So it will be around 48.57. So it's around 49 units because as I said, most of insulin pen, they don't have the half unit. Initial insulin to blood glucose is 1,249, which means 1 unit of insulin will lower his blood glucose by 49 milligram per deciliter. So 1 unit will dispose 49 milligram per deciliter of blood glucose. So what we will do, we use this ratio to correct his blood glucose and then monitor blood glucose and then start to adjust as we did before. So for example, calculate his correction dose if his blood glucose is 300 milligram per deciliter. So if it is 1,249 and the target is 120 milligram per deciliter, what we will do? So we will deduct the target, which is 120 from the current blood glucose, which is 300. So 300 minus 120, so it's 180 milligram per deciliter. And then the correction units are 180 divided by 49 milligram per deciliter. So it's around 3.6 units, it's around 4 units. Correct blood glucose, we use that and then monitor blood glucose and then adjust the insulin to blood glucose or correction factor. Let's see, for example, he used this for correction and on day 1, before correction, it was 300 and then after correction, it was 180. And on day 2, he got an hyperglycemia and it was before correction is 250 and he used 3 units and then he got 160. And you can see that he's still not reaching the target and he's having hyperglycemia. Why is that? This means that the insulin to blood glucose ratio should be adjusted and the insulin in the blood glucose ratio is insufficient or not sufficient to dispose the blood glucose. So in this case, what we will do, we will reduce the blood glucose in the factor, or in other words, we will increase the insulin in the ratio. So suggest a new insulin to blood glucose. The old one is 1,249. This 1 unit is not sufficient to reduce his blood glucose by 49. So we will make it 1,240. And we will start to use it as a correction for the correction doses, monitor again and adjust. After 1 week or 2 weeks, the patient will be able to know his insulin to blood glucose ratio. There is also an adjustment or fine tuning that we can do. For example, here, if the other case, the hypoglycemia, let's say the patient was 300 and 250 and see after correction, he got 80 or 75. This means that this ratio should be adjusted, and blood glucose in the ratio should be increased, or in other words, the insulin in the ratio should be decreased. This means that 1 unit of insulin is not really lowering by 49, it lowers by more than 49 in the ratio. So what we should do, we increase the blood glucose in the ratio, and we will make it 1 unit disposes 60 milligram per deciliter from blood glucose, or lower blood glucose by 60 milligram per deciliter. Again, we use it and monitor and adjust until we reach this. Another fine tuning that we should do is the meal plus or minus correction. Why we should do that? Let's say, for example, the patient blood glucose is 300 milligram per deciliter and he would like to take his lunch. We will not tell the patient, okay, inject yourself for the correction and then inject yourself another injection for the meal. No, we want to know how to do an adjustment and combine both doses in one dose, so he's not being injected too many times. So let's say if we calculate the pre-meal total insulin for Mr. MK, if his current blood glucose is 220 milligram per deciliter and his target blood glucose is 100 milligram per deciliter, and let's say he's planning to eat a meal containing 30 grams of carbohydrates. So bolus insulin for the meal, here is the insulin to carb ratio is on the left side. So you can see that 30 divided by 15. So he will require 2 units for a meal containing 30 grams of carbohydrates. So bolus insulin for correction, that we will take his current blood glucose 220 and his target blood glucose is 100. So we subtract the 100 from 220 and then divide it by 60. So 120 divided by 62 units. So what we will do before the meal, total pre-meal bolus insulin, we put the meal insulin plus or minus the correction insulin. So 2 units plus 2 units, and so the total is 4 units. So before the meal, he's going to take 4 units, not 2 units for the meal. 2 units for the correction and 2 units for the meal. Let's see if the situation is different, if he's having hypoglycemia before the meal, or if he's having, slightly lower blood glucose before the meal. So calculate pre-meal total insulin for Mr. MK if his current blood glucose is 70 milligram per deciliter and his target blood glucose is 100 milligram per deciliter. He is planning to eat a meal containing 30 grams of carbohydrates. Bolus insulin for the meal, as we did before, it's 2 units. But what about bolus insulin for the correction? You would say, oh, this is an hypoglycemia, we'll do correction. No, we'll do opposite correction, minus correction and not. So in this, what we will do, 70 minus the current is 70, minus 100 divided by 60, so minus 30 divided by 60, so half unit is there to be corrected, but it's by minus, not by positive. So the total pre-meal bolus insulin, meal insulin, plus or minus correction insulin, so 2 units minus 0.5 units. In this situation, his units of insulin is 1.5, but because he's going to have hypoglycemia, he started to be low, he's lower than 80 and he's on the 70. We reduce the units of insulin and it become 1 unit before the meal instead of taking 2 units before the meal. So this is the daily adjustment. So in general, what we talked about in the MDI or basal bolus regimen, we knew how to calculate the basal insulin dose, the initial dose, and the meal doses, and the correction doses, and how to make it plus or minus with the corrections. And then we knew how to do the fine tuning or adjustment and to reach the actual dosing. I'd like to tell you from my experience, it takes around 1 to 2 weeks maximum to adjust all of these for the patient, and the patient will just flow easily every day in adjustment and the adjustment of his doses. And basal insulin will be fixed for quite sufficient time until he comes to the second visit to the clinic, and also his insulin to carb ratio will be okay for some time until he comes back to the clinic, and also his insulin to blood glucose ratio will be okay. So let's see now, increasingly patients from type 1 diabetes, they like to follow the low carb diet uh, like type 2 diabetes. But for type 1 diabetes, we need to highlight a few things for the low carb diet. Low carb diet its advantage for the type 1 diabetes in reducing mealtime insulin doses for type 1 diabetes, because low amount of carbohydrates in the meal means low insulin dose before the meal and low calculation errors. That's a very nice thing, that it reduced the calculation errors. They can achieve, studies had showed that they can achieve better glycemic control on low carb diet and lower fluctuation in blood glucose throughout the day. Um, the fixed doses should never be used for low carb diet. So if the patient comes and asks you, I want to follow low carb diet, and he's using a fixed doses, like for example, 6 units for the breakfast, 6 units for the lunch, and 4 units for the dinner, you should advise him that doses with a low carb diet. He should learn how to calculate based on carb counting, and then he can only start the low carb, following the low carb diet. If the patient chooses to follow the low carb diet, we usually consider the protein also in calculating the dose. So we consider 30 to 50% of the meal protein grams in the meal insulin dose. Why is low carb diet is good for type 1 diabetes? If the patient is having high carb meal, he will have high insulin dose. High insulin dose will increase insulin resistance, and insulin resistance will cause more increase in insulin doses that is required by type 1 diabetes patient. So unfortunately, type 1 diabetes patients, when they eat always high carb meals, after some time, they start to develop insulin resistance, and they got some term called double diabetes. What does double diabetes means? This means that the patient who is type 1 diabetes and then he got insulin resistance, so he become like type 1 and type 2 diabetes patient, which is very deteriorating for his case and will cause a lot of complication. So this is what we call double diabetes. Here you can see, for example, an example on the left side is a high carb meal. This is 1 cup of cooked white rice, and you can see it contains 48 grams of carbohydrates. And here is 1 cup of cooked cauliflower, and it contains 5 grams of carbohydrates and 3 grams of fibers. Here it contains 1.7 gram of fibers. And just imagine the doses of insulin, how much it will be for the white rice and how much it will be for the cauliflower. And 5 grams, probably some patient, they can eat a meal and snack with only 1 unit of insulin on the low carb diet. So last thing I would like to say is my take-home messages for you. The MDI might make a physiological release of insulin. MDI gives patients more flexibility. We have to explain this to the patient to encourage them to follow the MDI. MDI provides better glycemic control and improves quality of life of the patient. That's available in studies and in research evidence. Monitor fasting blood glucose to adjust the basal, and monitor brandial blood glucose to adjust the insulin to carb ratio. Initial calculation should be adjusted to reach actual doses, and follow the 6 steps for bolus dosing, which I showed you in a diagram. It may look difficult, but patients get used to it by time. Keep going. Difficult roads always lead to beautiful destination. Here I will mention for you some resources if you are interested in helping diabetes patients who are using insulins. The first book is Think Like a Pancreas for Gary Shiner, and he's a diabetes educator. He's a consultant with the American Diabetes Association and several other associations in helping diabetes patients. He's also a type 1 diabetes patient. The second resource or book is Professor Richard Berneistein, The Diabetes Solution. He's also a type 1 diabetes patient, and he's an endocrinologist. and he's very famous for making his patients were always within normal blood glucose and not even elevated, same as a normal people. By the way, Dr. Richard Bernstein is around 88 years, and so far he's the longest age for type 1 diabetes patient globally, and he's very healthy person. This is the Tracy Brown, the CEO of the American Diabetes Association, highlighting the book of Dr. Richard Bernstein, and she went to meet him several times and highlighting his approach in adjusting. This book is very good. Some patients, they consider it the holy book of their glycemic control. Also here, there's a book from 10 to 5 for Ahmed Afifi, and he's diabetes educator. He's the famous diabetes educator in the Arab world because he has books in Arabic also. From 10 to 5, he means he lowered his HbA1c from 10 to 5. And he describes his journey and how he did the carb counting, and that was very helpful for him, or he followed the MDI, and that was very helpful for him. If you are looking for websites, you can go for the Diabetes UK website, and you will find a lot of helpful tools. And also you will find calculated meals and calculated recipes. I mean, you just find the recipe and give it to the patient, and you find calculated meals. They don't need to calculate, they just cook the recipe, and they just they know how much carbohydrates in the meal. There's also the UCSF diabetes education online, and you find a lot of resources. Also, Dr. Richard Bernstein, I just mentioned, he has a YouTube channel which he calls Dr. Bernstein Diabetes University, and you get to learn a lot from this YouTube channel. At the end, I'd like to thank you for your listening, and I hope you enjoyed this presentation. And I'm very, very glad to take your questions.